Welcome to the Mayo Clinic Ophthalmology Podcast, brought to you by Mayo Clinic. I'm your host, Dr. Andrea Tooley.
And I'm Dr. Eric Bothan. We're here to bring you the latest and greatest in ophthalmology, medicine, and more.
In this episode, we are chatting with Dr. John Ebbert, the director of the Mayo Clinic Nicotine Dependence Center, all about smoking cessation.
Dr. John Ebbert is a professor of medicine and the medical director of the Nicotine Dependence Center here at the Mayo Clinic. He's also associate chair for innovation and advanced analytics in the Department of Medicine and both vice chair for research and section lead for telehealth in community internal medicine, geriatrics, and palliative care. Today we will discuss his insights into nicotine dependence, implications in health and ophthalmology, and resources to break the habit. Welcome, Dr. Ebbert.
It's a pleasure to be here. Thank you.
We're so excited to chat about smoking cessation, how we talk to our patients about smoking, what the kind of nicotine epidemic is, and your experience. We've been kind of chatting offline. I've already learned so much. Kind of take us through your career path, if you don't mind, and how you got to where you are today, and how you got to be the leader of the Nicotine Dependence Center, and what that even means.
Yeah, I appreciate the question. So in the early 2000s, when I was starting my longitudinal care practice in community internal medicine, I noticed that a lot of my patients were dying from tobacco, and there weren't a lot of great options for us. And so really my journey has been to try to develop new options, develop new therapeutics, and really start to have a much broader strategy to engage patients in the treatment of tobacco dependence. And so that brought me to where I am today as the medical director. It's been a long journey, but it's been a wonderful journey.
I must admit, for us, and Andrea and I care for thyroid eye disease, but there are a number of conditions for our patients that we see that we know have some relationship and risk to smoking or other nicotine-dependent habits that they might be making. And for me, as I sit there and I say, I'm going to do your strabismus surgery after your thyroid eye disease, for an example, and I know patients with thyroid eye disease will have a more complicated course if they're continuing to smoke.
Yep.
We tell them, please stop your smoking. And so often they come back and they're still smoking. It's such a challenging thing for ophthalmologists to, meaning well, advise their patients well. So I'm excited to just have sort of this session to educate us, inform us, and just bring awareness to what we might do for them. But before we get there, let's just talk about current trends for nicotine use in all platforms. And I think about chewing tobacco and then smoking, and now there's this vaping stuff. But share with us the demographics of how youth or individuals in their life often get in. What are the stats on that? And then what is the balance of the different platforms by which they use this habit?
Yeah, so I appreciate the question. So our smoking rate in the United States is the lowest it's been in a really long time, 11.5%. So about 28 million adult smokers in the United States. And when we look across all tobacco use, that still remains the most prevalent. And one of the reasons is that cigarette smoking is so addictive. And the addictiveness of any drug is directly related to how quickly it can get into the central nervous system and in what concentration. So smoking something and inhaling it is faster than any other form of delivery. And so I think that explains part of that. A lot of this has been marketing as well, and just some of the other tobacco products are not marketed as heavily. E-cigarettes came on the scene, and they've really taken over a lot of the youth market. So if you look at e-cigarette consumption, it's much more prevalent in the youth than it is among adults. And a lot of that is marketing and specific campaigns toward adolescents. When we look at hookah, they have hookah bars. Yes, that's true. The prevalence of hookah hasn't really changed much, nor has smokeless tobacco. And I think we talked about in our pregame session, we don't really see pipe smokers that much. So when we look at it, I think it's always a constantly evolving playing field. It's also important to remember that the FDA has a very specific task to approve for marketing tobacco products, and the FDA has approved for continuing marketing e-cigarettes, as well as a very low nicotine cigarette, as well as smokeless tobacco in one of their authorization pathways. That means that the idea that we're ever going to put the tobacco genie back in the bottle and make tobacco illegal is never going to happen in our lifetime. So we're going to have these products, we have to manage to these products, and your patients are going to be using them. The other thing you mentioned, timing is everything, right? So when you see a patient in a perioperative discussion and they're stressed out and they have anxiety and nicotine is the only thing that helps them manage their anxiety, it's tough to counsel in that space, isn't it, really? Mm-hmm. And so a lot of times, taking the patient out of that context and referring them to us or referring them to other options, which we can talk about, is sometimes really helpful. You say, look, it's going to help you with your surgery. It's going to help you with your recovery. Maybe I'm not the one to kind of help you get there, but we have teams who are dedicated to help you and maybe getting a little bit distant from that. I'm not saying you shouldn't intervene. You absolutely should. That's the time to say you need to do this. And they're going to listen to their surgeons, but they just don't know how to be successful.
And in the vaping group, how much, a lot of youth might start out vaping, but then some might migrate to smoke later. What's the balance there of what the typical, when a youth starts vaping, what's their trajectory look like?
It's a great question. They've asked a couple of interesting questions. They first looked at, if you looked at people who start smoking an e-cigarette, what is their transformation rate to smoked conventional tobacco cigarettes, right? Because that's really what you're concerned about. The most risky product on the market, bar none, is smoked tobacco conventional cigarette, right? And an e-cigarette is harmful, but let's just be honest, it's less harmful than a conventional cigarette. So if you had youth picking up cigarettes, what you're concerned about is, are any of those youth people that otherwise would have smoked conventional cigarettes, and also too, how many of them use e-cigarettes as a gateway to conventional cigarettes? So it's actually kind of a break even. They don't think it's saving any kids from not smoking cigarettes, but we're also too observing that about a third of kids who pick up e-cigarettes convert to conventional cigarette smoking, which has the most risk. So on balance, probably no effect in terms of preventing youth engagement with tobacco.
And then one more question, where do cigars fit in this mix?
Good question. So cigars, have had some ups and downs over the past couple decades, and we always look over what is interesting for me is what's been going on over the past 2 decades, because I think that really gives you, an idea of kind of what cultural trends are and those sorts of things. Cigars they had an upswing in 2010s, 2015s. There were some changes in their ability to market that occurred. And cigars can be just as risky as smoking a conventional smoked tobacco cigarette, because a lot of those people inhale. And the other thing is, if you've ever seen someone smoke a cigar, they sort of marinate in the smoke. It's a real heavy smoke with lots of particulates that sort of hover in the air, and they're inhaling that. And they're inhaling that smoke, and it's a very heavy smoke. And cigar tobacco actually has more tar than a conventional cigarette. And the tar is the risk. The tar is what goes into your lung, carries the nicotine with it. The nicotine gets absorbed, and the tar stays behind. Tar is pharmacologically inert. And in fact, emphysema can be viewed as sort of a autophagy. So you've got cells that go in there and attack the tar, and they release cytokines that destroy the lung tissue. It's not the tar destroying the lung tissue, it's your body trying to protect itself from the tar. So cigars have a lot of tar is the point of that story. So they're certainly not risk-free.
Theoretically, if you weren't inhaling, then it would be slightly better? That's what everybody that smokes cigars says. Well, I never inhale them.
Yeah, so sure. So I think the thing that you think about is that smoking any kind of tobacco, anything you burn at 3,000 degrees Celsius on the lit end of any tobacco product actually is what they would call in cancer is a field effect. So whatever tissue is exposed to that tobacco, i.e. your mouth, repeatedly inhalation and exhalation, even if it's in your mouth, you can get oral cancer from that. And the oral cancer risks are very similar between cigar smokers and cigarette smokers.
That's interesting. I have to admit, like Eric was saying, we have these thyroid patients that we share, and ophthalmology, smoking is very important with macular degeneration, cataracts, all kinds of things. But especially with our thyroid, those are the patients that I say, I will not operate on you if you're still smoking. And I must admit that smoking cessation discussions are my least favorite. They make me so uncomfortable. Smoking and weight loss, those are the two things I hate talking to my patients about, because they don't want to hear it in my mind, or they've heard it a million times. And I feel apologetic. I'm so sorry I have to tell you, but you got to stop smoking.
I apologize too.
Do you?
All the time.
Yeah.
I know.
And so in all of your years of experience and wisdom, give us your best tips for motivational interviewing, encouraging your patients to stop smoking in a positive way.
So what I try to do is I try to meet, which I think is very common in all of addiction treatment. Tobacco dependence is no different. The difference between nicotine and all the other drugs is that you can use nicotine and still be functional, right? You're not impaired. You can still hold a job. You don't leave your family and become homeless because of it. So, I mean, it has a lot of other attributes that are very different than other drugs of addiction. So the social context a little bit different. But having said that, I think with all other drugs of addiction, it's meeting the patient where they are. So what I've tried over the years, and I've tried different things, of course, I apologize. I said, it's my job to do this, and it's your job to say you don't want to quit, and we move on. But, and I get it, right? I'm supposed to be the guy, right, that knows how to do this, and it's challenging. But one of the things I do see is I say, it is fun to smoke, isn't it? And you have to be careful a little bit about that. Motivational interviewing teaches you that you don't want to engage in a discussion that is promoting the behavior, supporting the behavior. Like, smoking is fun. Yeah, let's go smoke together. You're not doing that. But what you're doing is you're meeting them in a place where they want to talk about it with you. So when you go in there and you say, I need you to quit, I'm sorry I have to do this, they feel shame. They don't really, no smoker is really truly proud of it. Because I've never met a smoker who quit and said, I wish I never would have quit. But I've certainly, every smoker I've seen, I'm glad I quit. So I think that they all have that experience. It's just that it's really hard to see down that road to be what the biggest thing for me, that when connecting with my patients that I found, is when you ask them the question, what would it be like for you not to be smoking? They have no idea what that feels like. They don't know how to live without it. It becomes their best friend. It becomes their coping companion. And so trying to understand that, it's like trying to break that habit. You got to meet them where they are. Why do we use? Does it help you manage stress? Does it help you manage depression? The answer of all those is going to be yes. Like, when do you smoke? And they go, I don't know why or when I smoke. I just smoke all the time, right? So but they use it so commonly that I think engaging them and meeting where they are is really, really important. I always use scaling questions, like, how motivated are you to quit? On a scale of 1 to 10, how confident are you in your be able to quit 1 to 10, and kind of exploring that. If someone says, I have a 3 confidence, you go, oh, great. Why wasn't it a 1? Like, what gives you some confidence? It gives you opportunity to start to have a conversation with the patient and sort of engage them where they're at. Easy tip.
Okay.
Yeah.
I like that.
Pro tip.
Pro tip.
So commonly, I oftentimes refer to the smoking cessation clinic as an option for them, or their primary care. And some people come back and say they tried gum for a while, or they had a patch, or these other options in nicotine replacement. Share with us, just within medicine, how valuable is it to in terms of health risk to transition to that? I mean, in surgery for you, I think you still do proceed as long as they're on a nicotine replacement option.
Yeah, I'm okay with nicotine. I just don't want the smoke.
The smoke. So share with us, just as they come to the smoking cessation clinic, you're engaging them where they are and giving them options. What is the usual process for caring for them, looking at options, evaluating their life, and choosing next steps? And what might those next steps be?
Yeah, so we have 3 drugs. And when we think about tobacco treatment holistically, it's really a 2-pronged strategy. It's the behavioral strategy along with the pharmacotherapy. So I work with counselors who help with the behavioral strategies, which are how to avoid how to avoid triggers, how to identify cues, and all of the behavioral components of quitting. And so we have our counselors work with that. When we do the pharmacotherapy, we think about three options. We have a medication called varenicline, which acts very specifically in the addiction centers of your brain. We have bupropion, which is an antidepressant, which can help with craving. And then we have all the nicotine replacement products, which include gum, lozenge, nasal spray, and patches. So those are and what I typically do is I say, what have you tried before? Because usually they have some very strong feelings, and it's rare these days that I meet, especially in the referral practice that I have, that I meet someone who hasn't tried to quit before. I usually try to identify what they've tried to use, what they're interested in using, and some of that's based upon previous experiences. And then that's really where I start my conversation, is what they would be willing to try. And we talked a little bit about in the pregame here about insurance coverage, which can be challenging, of course, but we can work with prior authorization, and we'll work with insurance companies, as you both of you do in your in your surgical procedure practice. We do the same thing with our medication, so we can work through those things. So that's how we start, really. What have you tried before? What are you willing to try? And then really engage with the behavioral components in addition to the pharmacotherapy.
Are most patients coming in the door the first time interested and engaged and ready to commit on multiple modalities? Are they on a systemic medication and replacement, or do you try one and add in the other over time, or what's the usual step therapy versus hit them hard and back off?
It's an important question, because some of the data suggests, it's very interesting, if you actually look at data of patients that walk into your big box store and take a nicotine replacement off the counter and use it on their own, they're less likely to quit than someone who had never even done that. Why would that be? And the answer is because what happens is they don't have the knowledge to dose high enough, so they think it doesn't work. It doesn't help with craving. It doesn't help them be successful. So it actually works against cessation.
It becomes defeating.
Yeah. So it becomes defeating. So really trying to engage them at that level of trying to figure out, what works and how do we start. And we like step therapy. So step therapy is very common in medicine. We do it blood pressure and diabetes, all of these modalities and diseases that we treat. But we'll start out with one or two products if they've never tried them before. And the next step is really combination pharmacotherapy. So a patch plus gum, or a patch plus lozenge. The patch provides continuous dosing, and then the gum, the lozenge, and the nasal spray provide ad-lib dosing for acute urges. And then we'll add varenicline, and we can use varenicline with the nicotine patch. And sometimes we use all the medications at the same time. So I don't like to, get all of the big guns out right away. I like to ramp them up so that I have something to go to on their next attempt. More recent data suggests, it used to say that most smokers try to quit 12 times before they're successful. The data actually suggests it's more like 30. We like to reduce that to more like 3. And the way that we do that is we try to use, combination pharmacotherapy with the behavioral strategies.
Wow.
So what would be, just if you had a cohort of individuals trying to stop smoking on their own after 10 years, what success does a population find? And then number 2, what's the data behind smoking cessation clinics like we have here at Mayo on impact on that habit? Yeah,
so what's interesting and important to remember about tobacco dependence is that there's a very strong correlation between abstinence rates, and that's quitting. And our gold standard is 6 months. We check at 3, but really 6 months. And the reason why is that when we get a patient to quit for 6 months, the likelihood of relapse becomes almost like a flat curve. If you look at that with abstinence as your y-axis, most of that relapse is happening within the first 72 hours. 70% of patients are relapsing in the first 72 hours. So if we can get them out to 6 months, we're feeling pretty good about that. And the more intensive the therapy, the higher the quit rates. So on your own, 5% of the patient of the smoking population quits. With our treatment, Mayo Clinic Nicotine Dependence Center, 25% at 6 months. With our intensive treatment program, which is an outpatient program where they stay in a hotel here in Rochester and we see them every day, it's about 50%. Wow. And when you look at even the most effective medication, which is varenicline, at 6 months, 2/3 have relapsed. We don't have a lot of drugs, and they don't work that well, so we've got to use them all together. That's the key.
It's absolutely wild. And you mentioned when we were talking before, too, about how challenging it is that we get so many deaths per year from tobacco. We have so few drugs, so few things coming out on the market. It's unlikely to have new drugs coming out on the market. Talk to us about that, because it's such a good point. I didn't even consider it, and it's really shocking.
Yeah. So without sounding too cynical, 480,000 people die still each year in the United States from tobacco-related illnesses. That's equal to 3 fully loaded 747s crashing every day for an entire year with no survivors, because that's a helpful frame, because it's hard to imagine what 480,000 actually looks like. So that's helpful. I only have 3 drugs that I can use, and the last new drug I had came out in 2008. And then I think about acne, where it doesn't really kill anybody, but I have about 30 drugs. So it's like I said, I'm trying not to sound cynical, but that's why I actually lean into, intensifying that therapy, doing more than just one thing and really trying to use multimodal approaches.
So how unique is that? So, I mean, and just share with us what makes the Smoking Cessation or Nicotine Dependence Center here at Mayo unique in terms of research or frontiers of intensive therapy.
Yeah, so we do something here that not a lot of other institutions do, and that is we dose match. And the dose matching is if you smoke 40 cigarettes a day, which is 2 packs, 20 cigarettes in a pack, unless you live in Canada, in which case it's 25. But if you smoke 2 packs a day, that's 40 cigarettes. The first patch dose we'll put you on is not a 21. We'll actually put 2 21s on you, and it's a 42. So we match the cigarettes you smoke per day with the number of milligrams in the patch. Because our early studies found that patients do better when you try to give them 100% nicotine replacement. So they did this fascinating study and it's not just all about nicotine either. So what they did was every smoker has a nicotine set point, and they smoke to that nicotine set point. And there'll be either 15 cigarettes a day or a pack a day or 10 cigarettes a day. Everybody kind of has that sweet spot, if you will, with nicotine. And when they took these patients and they said, okay, what we're going to do is we're going to figure out how much nicotine you get a day, and we're going to infuse that in your vein and see if it gets rid of all your cravings. It got rid of most and not all of the cravings. So even though we dose match, the rest of that story is you still have to use those behavioral therapies, because nicotine and drug craving is not all just about the drug. And they also, one more study I want to tell you about. They did a very interesting study with functional imaging of the CNS, and they looked at the reward center of the brain that lit up among people who were injecting heroin. And they found that the dopamine was released even before the needle was put in the arm, because the association with the drug experience was so strong. That's all they needed to get the high. And we believe that happens in smokers, although they haven't exactly replicated that among cigarette smokers. But that behavioral component, even if we're really going after those high-dose nicotine patches, is such a critical piece. Wow. And it's hard for you to do that, right? In ophthalmology, you don't have the time. That's what we're here to help you and support you. And there's also some other things I can mention in terms of what patients can do on their own.
It's really helpful to know that there's lots of support out there besides just in our clinic, because it does seem daunting for us. And I have a few memorable patients. I had one young patient, I'll never forget, who I said, I will not operate on you until you stop smoking. And this patient was so angry with me and said, I'm not ready. I don't want to. You're forcing me. Was really upset.
She dug in her heels.
Yeah. And I'll never forget her saying, I'm not ready. And I thought, well, you're never going to be ready. Who is ready to quit smoking? So that behavioral piece, and then even the data that you presented, with the most intensive care, it's still only 50%.
Correct.
That just shows how addictive these things are. It's unbelievable. How do we stop patients from starting? Are they all starting when they're young?
Yeah, so what's fascinating about addiction is that about 99% of all addiction happens before the age of 25.
Wow.
And we know that the brain continues to develop until the age of 25. And if you can keep a kid off of a drug or unexposed to a drug until after the age of 25, the likelihood they'll ever be an addict is less than 1%.
Impressive.
Wow. Is that the same with alcohol?
Everything.
Wow.
All the drugs are the same.
Wow.
That
So
is
till
striking.
25.
Yep. And that's because during that
fascinating.
age of experimentation
Yeah.
and brain development, risk-taking behavior, trying different things, trying to think about, seeking that high, seeking that dopamine rush, and drug experimentation is a risky time for during brain development.
Wow.
Talking about drug experimentation, can I just ask you this?
Please.
Given your expertise, marijuana has become the cigarettes of of yesteryear.
Right.
It's just it's not only just an opportunity that's seen as should be open in society, but it's actually in some circles trying to be used to promote whatever there might be, whether it's glaucoma or which much of this is not proven medicine. But how has the push for marijuana to become legalized made your life harder, or made our society, brought in new challenges that we might not talk about, but you experience every day?
Yeah. And as I think about it, it's just really the next healthcare crisis, right? Tobacco is a healthcare crisis. This is the next wave. And because we know that there's very good data that daily exposure to cannabis during developmental, the development of the brain can really lead to long-term consequences on cognition. We know that from decades of experience with European data. So it's just the next healthcare crisis. For us in tobacco, what's happening is they're developing all sorts of new delivery devices which facilitate the co-administration of nicotine and cannabis. And co-administration of drugs in the drug world is pretty common. So people will do what they call an 8-ball. And an 8-ball is heroin and cocaine at the same time. They'll inject that. And the reason they do that is because heroin, provides profound euphoria, but it makes you sleepy. So the cocaine sort of counterbalances that sleepiness effect. And they do that with alcohol and nicotine. Nicotine can be very sedating, or nicotine can be very stimulating. Alcohol can be very sedating. So the co-administration of drugs is very common. So cannabis can be relaxing, but it can also be sedating. So the co-administration of nicotine as a stimulant is what we're going to see more and more of. And then delivering these through, we think that it's safe because we're not smoking a joint anymore. But what they're doing is they're heating it and they're aerosolizing that nicotine and that cannabis together and then co-administrating it through inhalation. But it's not smoke, right? It's not burned organic material. It's actually an aerosol of cannabis oil, cannabis, and nicotine.
It's in the vaping group.
It's in the vaping group.
All more
You used a comment
processed.
earlier off when before the show we
We're
talked
learning
about
all the
blunt,
terms.
and that was another one I
Yeah,
had
the
heard of,
blunt,
which is
yeah.
marijuana inside a cigarette.
Marijuana inside a cigar.
cigar,
In a
So you
cigar.
get some nicotine from the
Yeah.
cigar.
Yeah, exactly. Because a cigarette is a tobacco rod rolled in paper. A cigarette is a tobacco rod rolled in paper, and a cigar is a tobacco rod rolled in tobacco. So that's why they use the blunt to.
Oh, I
Yeah.
didn't know that.
Yeah. Yeah.
So there's so
We're
many
very naive over here.
implications and thoughts in different locations. Minnesota has a very aggressive tax on cigarettes, my understanding, or compared to national standards. But how impactful is that on the use? I assume it's
Financially.
not.
So not as much anymore. So most of the impact, so the two most effective strategies for reducing tobacco use at a population level are excise taxes and clean indoor air. Those
Right.
two. But you're not seeing that now because you had a wave of clean indoor air. I don't know if you remember eating in restaurants where they had the smoking and non-smoking.
Smoking section,
Someone had the analogy that was like having a peeing and non-peeing part of your pool. All that's been implemented, and there aren't a lot of new sort of clean indoor air spaces coming online because a lot of this is political and a lot of it is based on states. So your perception is not as effective is correct because we're not getting any new spaces online and any new significant increases in, tobacco excise taxes. But if you doubled the excise tax on tobacco, you would eliminate almost effectively 90% of the smoking.
Why don't we do that?
It's politics.
Oh my goodness.
All right, one more question. This is so rewarding to unpack a topic that we just don't talk about, other than these pearls
really
that we give our patients sometimes. Help us for listeners that might be a comprehensive ophthalmologist in a city around us, walking into their 13-year-old bedroom and seeing a vaping device in the drawer.
Right.
Or whatever it might be. And there's that initial reaction that you pull your son or daughter into the living room and have this really critical, harsh discussion probably. But share for the parents out there. When should we be talking about our kids? And it should probably be throughout life in these regards, but as their young life. But just advice for communication prophylactically, but then advice for that initial awareness that this is in their house, and might it be more than just a discussion one-on-one with your child?
Mm-hmm. First of all, pause. Breathe. If you're not ready to have a calm conversation, leave the room and come back, because you have to start with a place of empathy or you're going to push the kid away. So that's just my parenting advice. But anyway, coming from an addiction specialist, we see this because I see it among adults. Same thing. They have the same response. If it's not from a place of compassion and empathy, they want to dig in and throw up the resistance, right? Mm-hmm. So I think that it's important for them to get the information that they need. E-cigarettes are safer than conventional cigarettes, but they're not completely safe. They do create, because of the heated coil system, with the vegetable glycerin and the propylene glycol inside those vaping systems, does convert to carbonyls like formaldehyde. And that formaldehyde, as you know, repeated inhalations of formaldehyde, as you might surmise, is risky and can lead to cancer. It's a carcinogen. So starting with information, and then also knowing that these kids are being exposed to very high levels of nicotine. They just released a study when they looked at positron emission tomography of carbon-11. They took carbon-11 and basically combined that with nicotine, and then they had smokers smoke a conventional cigarette, an e-cigarette, and then an e-cigarette with a salt. And a salt is a different form of nicotine that they use in e-cigarettes. And the delivery of the salt form with an advanced e-cigarette, nicotine in the central nervous system look exactly like a smoked conventional cigarette. So they are achieving serum and blood and CNS, central nervous system, concentrations of nicotine that look exactly like a conventional cigarette. Mm. So if you see a 16-year-old with an e-cigarette, they may be just as addicted as a 20 cigarette a day smoker that you see in the ophthalmology practice needing an ophthalmologic procedure. Just as addicted. So to say stop is going to work as well with that kid as it does it working with your patients in ophthalmology. So they might need help and they might need treatment. And so calling a quit line like 1-800-QUIT-NOW. 1-800-QUIT-NOW is a state-run quit line. They can get help. Truth Initiative has a Stop Vape program that they can get for free to try to. So I think having the conversation, giving that child that information, and then getting them help is key. Expecting that they'll quit cold turkey just means the behavior is going to go underground.
Right.
Thank you for that advice.
Yep. Yeah, good advice. Terrifying. Wow. Well, I've learned so much, really. Your expertise is phenomenal. Thank you so much.
Yes.
And we'll try to meet our patients where they are.
Perfect.
Give them some data and then refer them to you. That's my plan.
Much appreciated.
Sounds good. Thank you so much for having me.
Thank you, Dr. Ebbert. You can find all episodes of the Mayo Clinic Ophthalmology Podcast on our website.
Thank you for listening, and we definitely look forward to sharing more